Everybody, good morning. Please take your seats. So everybody, thank you for coming. I would urge you to step forward, but I guess you're not going to. So we're just about to start. I'm sitting in for Professor Angela Vincent, and let's present. So this is Dr. Brian Weinshenker and Dr. Thomas Berger. Dr. Weinshenker is a professor of neurology. First of all, it's a great honor to present you two, and I'm glad to sit here with you. Dr. Weinshenker is a professor of neurology at the University of Virginia, consultant at Mayo Clinic, Rochester, Minnesota. His major research interests are inflammatory demyelinating diseases of the central nervous system, with special interest in classification, normally optica spectrum disorders, differential diagnosis of acute myelitis, myocardial sign, and course of multiple sclerosis. He was awarded the 2011 John Distel Prize for MS Research. Dr. Weinshenker.
Thank you very much, Avi, and welcome to everybody. It's a great honor to kick off this CONI program for 2025, and we have an exciting debate to begin. There's a QR code, and please scan that in order to get your CME credit. The title of the debate is MOGAD due to anti-MOG, that is myelin oligodendrocyte glycoprotein antibodies. And I'm going to move on to the slides. There should be some slides. Yes, thank you. And as moderators, we're supposed to be brief, so I will try to be very brief. I have no disclosures relevant to MOGAD, but I'll leave those up for a second for you to look at. MOGAD is a recently recognized CNS inflammatory disease. The clinical characteristics overlap with those of multiple sclerosis and AQP4 positive NMOSD. The symptoms are dominated by optic neuritis, but myelitis occurs, and in particular in children, patients experience acute disseminated encephalomyelitis. There are some very unique presentations, or somewhat unique presentations, such as unilateral cortical encephalitis or flame syndrome. There can be MRI abnormalities that can be characteristic, albeit nonspecific. MOG-IgG is currently felt to be essential for diagnosis, but there is some difficulty with false positives, particularly in patients who have low titer antibodies. We're talking in this debate about the pathogenicity of antibodies, and I don't want to steal the thunder of the speakers, but I suppose we will hear about the clinical association and how consistent it is, how specific these antibodies are, whether the antibodies precede clinical symptoms, which they should if they're causal, and whether this association is reproducible in multiple populations. Of course, in vitro studies of pathogenicity, and in particular, passive transfer experimental models are an important aspect of trying to address this issue. We do know that MOG-IgG is essential for the diagnosis, but that's rather by definition. There is some controversy whether some patients who have very typical clinical and radiologic characteristics may be seronegative MOGAD, although that's not an officially recognized entity. Injection of MOG peptides can produce inflammatory demyelination. It does seem that MOG-IgG is unique to MOGAD and rarely, if ever, seen in aquaporin 4 positive NMOSD or typical MS, but that may be a matter for debate. The antibody may predict relapses. There have been studies that suggest that, and the antibody can activate complement and the MOG antigen is theoretically accessible to antibodies, being on the extracellular surface. But the outstanding questions are whether this antibody is pathogenic. Is this disease purely antibody-mediated? Is there a role for T cells or other cofactors? So we're very fortunate to have two experts. The first who will argue the affirmative is Dr. Patty Waters, who's the scientific director of the Oxford Autoimmune Neurology Diagnostic Laboratory. Patty has had many contributions, has contributed to the discovery of immune targets for many different kinds of autoimmune encephalitis, including glycine receptor encephalitis, LGI1, and many others. He's had a major role in developing and validating assays, including international collaborative studies to standardize methodology for testing for MOG-IgG and aquaporin 4 IgG. And arguing the negative, we also have an expert, Dr. Thomas Berger, who's sitting at the podium, chair of the Department of Neurology at the Medical University of Vienna, who had trained with Professor Hans Lassmann in Vienna. He's a member of many national and international MS committees and really was a pioneer in studying the clinical significance of MOG-IgG in MS, publications in the New England Journal of Medicine dating back some 15 years or so ago. So with that introduction, I'm pleased to first ask you to vote, and we should be able to get a QR code that you can scan at Slido. So please scan this. And I think the next slide might give us the question. So the question is, again, is MOGAD due to MOG-IgG? And we're supposed to give you 10 seconds. We're probably at 7. So the vast majority of people think that 85% that it is due to anti-MOG antibodies. So Thomas, you're going to have your work cut out for you. I'm pleased to invite Patty to come up.
So thank you very much, Professor Weinshenker, for the introduction. And thank you for the organizing committee for inviting me to talk here today. I thought I had my work cut out because I didn't even get a seat at the top table, but I think the audience is on my side, which is nice. So these are my disclosures. Give me a chance to look through. Okay, so MOGAD and MOG-IgG have been given a really disrespectful title by the international committee that defined the diagnostic criteria for MOGAD. They call the disease MOG-IgG associated disease. You don't see aquaporin 4 IgG associated disease, and you don't see NMDA or IgG associated disease. They don't disrespect the antibodies like they do for MOG-IgG, and I don't know why this has happened. And I hope by the end of this I'll convince you that MOG-IgG is probably more pathogenic than aquaporin 4 IgG. So by the end, we'll all be calling it MOG-MED, MOG-IgG mediated disease, and not associated. Okay, so my background is developing antibody assays, so we'll start there with MOG-IgG. So on the top left-hand corner there, up here, that's the assay. It's that simple. You take cells, that blue circle, you express MOG in it, and we've used all of the isoforms, but the alpha-1 or beta-1 isoform are the most sensitive targets in this disease. You put patient's serum on with that colored antibody, and then you add a secondary antibody. For for diagnosis. Press this 3 times now. Great. Good. So on the top row, you've got HEC transfected with MOG, and on the right-hand side, a patient sample binding very nicely. You've got positive and negative controls in the assay. On the second row in red, you've got aquaporin 4 transfected HEC cells, and the patient sample does not bind to aquaporin 4 transfected HEC cells. So it shows it's very, very specific for the target that's transfected. And we use this to support the clinical diagnosis of MOGAD. When you look at large cohorts, so this is a review written by Marcus Reindl and myself, and on that, by cell-based assay, you've got the number of studies written down there. So in controls, were found in 17 studies, so 5,500 individuals, and 45 had MOG antibodies, so less than 1%. In MS, 1.5%, and aquaporin 4 antibody positive NMOSD, less than 1%, whereas the non-MS demyelinating disease, 30%, had MOG antibodies. So it looks like this test is specific for this disease. We're capturing a huge proportion of individuals with this non-MS demyelinating disease, which is largely treatable. So it's an important antibody to detect. So we live in a world that in neurology, you have antibodies against surface proteins where the antibodies bind to their target and can infect can impact the cells that express the target or impact the target itself. We don't know the function of MOG to a great deal, so that might be a reason why we're struggling with it. And it's unlike the paraneoplastic antibodies where you've got nuclear or cytoplasmic targets and the antibodies can't do anything. So Kevin O'Connor, in his lab, took HEC cells and he transfected them with MOG EGFP, and then he sorted them by flow cytometry. So you end up with a transfected population and with green tag and an untransfected population. So when you add serum to this mixture, you can pull apart the effect on those that are transfected versus those that are not transfected. So if we look at the untransfected cells first, what this assay is looking for is deposition of MAC on the surface of the cells. So you have MOG transfected cells, you add patient serum, you let the antibodies bind to the MOG EGFP transfected cells or the untransfected cells, then you add a source of human complement and look for the deposition of MAC on the surface of the cells. And on the untransfected cells, you've got 4 groups of patients, healthy donors, myasthenics, MOGAD, and aquaporin 4 antibody positive patients, and there's very little MAC deposition. You note the y-axis goes up to 20%. When you have the MOG GFP transfected cells, now you've got 2/3 of the patients very clearly and very specifically fixed complement. So this is patient serum, and if we swap over and look at monoclonal antibodies, which he also tried, so he took a B cell from a MOGAD individual, he cloned it onto 4 different backbones, IgG1, 2, 3, and 4, and then ran the same assay, and you can see that IgG1 activates complement very nicely on MOG transfected cells compared to IgG3. So there is no doubt that these antibodies are functional in an in vitro system. They fix complement either in the serum or as a monoclonal antibody. And what about in patient tissue? So Romana Hafberger and colleagues very nicely showed these are 2 autopsy cases with C9 neodeposition in the CNS tissue. There is an argument that this might be late-stage disease in autopsy, but here are biopsy samples. And in 8 out of 8 cases, she found what she describes as profound deposition of complement in these brain tissues. That was one paper, and here's another example, again from the O'Connor lab, with, I think, what you'll agree is profound complement deposition as well. So I possibly could stop here because we've got an effector function for the antibody, and it's very clearly present in patients' brains. But antibodies have other functions. So we look at ADCC, so antibody-dependent cell-mediated cytotoxicity. So in this assay, you've got a few HEC cells transfected with MOG. You add patient serum to coat the cells. You incubate at room temperature, and then you add some macrophage. And the macrophage have this purple circle on the outside, So that's cell trace violet. So by flow cytometry, you can isolate the macrophage. And after 4 hours incubation, then you're looking for the purple macrophage with the green in the center. And here's what you see. So in yellow and pink are either media or the healthy donor IgG, and there's about 2% of the macrophage who've taken up a bit of green. With the MOG IgG, it's 23%. And when you quantify that, you can see again about 2/3 of the individuals have phagocytic capability. There might be an argument that it's pinching the MOG from the surface of the cells and it's not killing them. So what Kevin also did was took the cells and counted what green cells were left. And you can see again in the MOGAD patients, there's fewer green cells left compared to the other groups. So ADCC is a function of this antibody as well. When you go to the tissue, these arrowheads are pointing to macrophage with a blue color, so that's Luxol fast blue. And this is myelin inside macrophage. And another example here from the same paper is a strong demyelinated lesion in the white matter. You've got activated macrophage or microglia concentrated there, and the arrows are pointing to a macrophage containing MOG. So we can't tell whether they're cleaning up or whether they're actively involved in the disease process by immunohistochemistry, but you've got some evidence here that they're involved. So there's 2 functions of antibodies that are associated with MOGAD. Now, MOG IgG also has a direct effect, a direct cellular effect. So these are oligodendrocytes. This is work done in Australia by Fabian Briot and Russell Dale. And they transfected the cells with MOG, and in the MOG transfected cells in red, you can see very strong binding on the outside of these transfected oligodendrocytes. When you purify total IgG from the patients, you get binding in red on the right-hand side. And if you target specifically identify MOG-specific IgG from the patient's serum and then put them on, you still get this specific labeling. So these are MOG-specific antibodies in this assay. So what they did, they looked at the oligodendrocytes, and in green you see beta tubulins. This is the cytoskeletal architecture in cultured oligodendrocytes. And what they looked at was the ratio of green on the outside in the cytoplasmic area of the cell compared to the green near the nucleus. And on these fixed cells, there's not much difference between these 2 groups as quantified on the right. When you let the cells alive, when you add the antibodies, then you can see a severe changing of the architecture within the cell with no complement. So this is purely just antibody binding to the outside of the cell. So there's some impact of the antibodies binding to the outside of the oligodendrocytes that's transmitted through MOG to the cytosolic portion. You don't see that with aquaporin 4 IgG. What about in vivo? So this is something we did about 15 years ago. So we had a CD1 mice, so they're an outbred strain of mice. We inject them with human complement and aquaporin 4 MOG or healthy control IgG, and we look at the tissue. And in pink on the left-hand side, we've got control IgG. The blue is a Luxol fast blue stain looking at myelin at day 1, 7, and 14, and we don't see much myelin loss. In blue on the right-hand side, aquaporin 4 IgG, and we see significant demyelination. And then with MOG IgG, we see initial demyelination, so it's highlighted in the red, but over the 2 weeks it recovers, and it's not as severe as the aquaporin 4 mediated antibody. So there's a little bit of demyelination. Whether this is destruction or changing the architecture, which impacts on the staining, I'm not sure. But what we do know is if you take that same serum and you pre-adsorb with HEK cells, the demyelination is still there, but if you pre-adsorb with HEK cells that express MOG, you lose the demyelination. So this demyelination is specific for the MOG IgG in the patient's serum. And when we look then in the CNS of these mice, the first picture in A there is neurofilament. So the neurons are unaffected by the MOG IgG over this 2-week period after a single bolus of injection. But when you look at the compact myelin it's really badly disorganized. Now, in this model, this complement injected it as well, so can't tell you whether it's mediated through complement or not, but what you can see is there's a severe impact uniquely in the MOG-injected animals on compact myelin. And when you look at the nodes of Ranvier, you can see that the Caspr2 is disorganized as well. So these antibodies directly impact compact myelin and the nodal architecture with a little bit of complement. And again, you don't see this with aquaporin 4 disease without complement. MOG, we always look for markers of relapsing disease. The best marker is persistent IgG, and this is work from Kevin Rostasi in Austria. So these are monophasic kids. These are endpoint titers of MOG IgG in their serum, and you can see in a, I've got this the wrong way around, I think. So yeah, these are the relapsing cases, and in the relapsers, the median dilution doesn't change over 6 to 12 months. That's about a doubling dilution. And in the monophasic kids on the right-hand side, you can see a real decrease in the titer. So there is a strong association between relapsing disease and persistent antibody. Again, a clinical indicator that these IgGs are critical to this disease. And then this is the B-cell developmental pathway, and aquaporin 4 antibody patients are treated with Rituximab. This is where Rituximab impacts, and these are the antibody secreting cells. I'm still a little bit at a loss as to why Rituximab actually works in aquaporin 4 mediated disease, because when you look at the serum titers after multiple rounds of Rituximab, you get the same antibody titer in the blood. It doesn't impact on complement, so it should cause disease. The caveat is we're looking in blood and not in the CSF, and there may be a story there. But this does not seem to work as well for MOGAD disease. And this is measured in a French study. So these diamonds are the presence of memory B cells. And in aquaporin 4 positive disease, if the memory B cells rise above this magic number of 0.05%, you tend to get relapses. There's one example where it didn't reach that number. But in MOG-mediated disease, you get plenty of relapses without reaching this magic memory B cell number. This, to me, says these MOG antibodies are much better than aquaporin 4. They're more robust. They're more pathogenic. And finally, early steroid treatment reduces relapse frequency and is also associated with a return to seronegative result. So this is work from Sungmin Kim's group in Seoul in Korea. So if you treat people within 5 days with steroids and you use that as your reference, you've got 32% relapsers. And if you treat them after 14 days, then the percentage of relapses goes up to 64%. So there's an associated time to risk of relapse with time to treatment, and also you get an awful lot more individuals becoming seronegative when they're treated early. So in summary, these are the points that I've made. I think MOGAD is very clearly due to MOG IgG. There's an interesting thought that maybe the recoverable swelling attacks that you see in MOGAD early in the disease are due to architectural change within the CNS, and steroid treatment removes that problem, and then the real disability is associated with cellular and humoral effector functions of MOG IgG. So hopefully I've convinced you that we should be calling it MOGMED, and thank you very much for getting up early to listen to us. Thank you.
So thank you very much for the invitation and also for the kind introduction. I would like to introduce that I completely agree with everything Dr. Waters said. However, as a neurologist, I'm always a little bit of anarchistic, because the question says, is MOG-AD due to antibodies? I have to say no. The association, which was very nicely presented by Dr. Waters, is, I think, clear, and I would like to elaborate in my 15 minutes that, first of all, the story of MOG antibodies is a long and winding road. And the other thing is that there is still something to do to drive the pathogenicity or the pathogenic traits of MOGAD apart from the antibodies. So these are my disclosures with no impact to the current presentation. And as I said, it is a long and winding road, and it started interestingly by identifying MOG antibodies and using those without knowing an appropriate disease, because it started as a kind of better resembling the experimental model of multiple sclerosis. And this is just to show that there are some quite ancient work I've been involved in, together with Chris Linnington from the Max Planck Institute in Munich. And at that time, of course, the Lewis rat was thought to be a good experimental allergic encephalomyelitis model for multiple sclerosis, but we all recognized that there is some extent of inflammation, but the model lacks demyelination. How should this resemble MS? Now, what we did at that time point, because there was the idea that encapsulogenic T cells against MBP are the major driver of this experimental model, and Chris Linnington, Hans Lassmann, and myself thought probably there are also other myelin antigens which could be targets of a encapsulogenic T cell reaction. And indeed, this is something which is well known, but it's also interesting to see that you not necessarily need a myelin target to introduce an encephalitis. You can take any antigen which is present in the brain of at least a Lewis rat, and this could be S100 up to heat shock proteins. Nevertheless, and this was the important thing, if you add to any kind of encapsulogenic T cell transfer to the animals in a co-transfer model, a MOG antibody, then suddenly you get patchy demyelination in the Lewis rat. And this is seen here on this right side. And interestingly enough, it only happens with MOG antibodies. So you can add MBP antibodies, nothing happens. You can take encapsulogenic T cells against MAG, PLP, any other antigen, and add MOG antibodies, you will get demyelination. So this was, of course, a very interesting finding, and together with others, of course, around the globe, we thought this was one of the magic bullets we found. However, there was, of course, certain developments, and specific MOG EAE was established in different animals models. However, and this is very important to know from this lesson, is that you can exacerbate EAE, you can induce demyelination, but you need the T cells before. So the antibodies alone do nothing in these animal models. Now, then it was, of course, further elaborated, and Brian Weinshenker already mentioned, we tried to establish MOG antibodies in S patients and also in CRS patients, and this was this mentioned New England paper where we thought that the MOG antibodies define the risk of individual patients for developing to clinical definite MS. However, this failed in routine practice for several reasons, despite the fact that some other centers and CRS cohorts showed that there are some associations and partly confirmation of our work. The majority did not. So what was the reason? The one major reason was the, at that time, insufficient or unreliable test system. And we did some ring experiments with a lot of people across Europe and also the US. And at the end of the day, it turned out that in this case, they are not specific for MS. You find them in any other condition, and interestingly also in those lab workers who are handling MOG EREs, because they're also exposed to MOG, of course. So this was interesting to find. But then there were, of course, certain developments, especially first indicating that if you really can detect conformational epitopes of MOG instead of linear, you can define that MOG antibodies are mainly found in ADEM situations. And this was a work from Kevin O'Connor some nearly 20 years ago. And then, and this is contribution to Patrick Waters, he did the seminal finding and work that we need a reliable test system to detect these antibodies. So at this stage, the first problem was solved. We have a consistent, sustained test system, a cell-based assay to identify those MOG antibodies. However, this, of course, and based on the methodological findings and the reliability and validity of the test system, the gold standard was established, and the MOG antibodies are a major contribution to the MOG-associated disease diagnostic criteria. However, we have now, out of the earlier thought that NMO or ADEM are part of the MS spectrum, now identified via the antibodies that there are two very specific disorders which are clearly own entities completely apart from MS. The one is NMOSD and the other one is MOGAD. But the crucial question, if they are defined by antibodies, we need to ask whether they are pathogenic antibodies or bystander antibodies. So if an antibody is a bystander antibody, it doesn't mean that it's a bad antibody, because you can use a bystander antibody for diagnostic purposes. You can use this for measuring tissue destruction as a kind of reaction on the tissue destruction, but it's different to a pathogenic antibody because the pathogenic antibody is per se causing the disease. Now, if we look at the pathophysiological mechanisms of NMOSD, and the good thing is that we have two antibody associated / mediated disorders driven by antibodies or defined by antibodies, but what are the potential differences? First of all, the antigen presentation, which is the target of the antibody, is quite different. And there seems to be a very unique situation in the NMOSD, which means that the antibody then forms so-called orthogonal areas of particles, which means that they allow a broader and better targeting via the antibodies. Whereas in the MOGAD and the MOG antibodies are confronted with much more diverse and scant antibody expression on the myelin sheets and on oligodendrocytes. And this may definitely also impact one of the major biological activities of those antibodies, or a pathogenic antibody, meaning to induce complement. And we heard already that the MOG antibodies are able to induce complement. However, we have also to confess that this is, as an example on the upper part of the slide, in organotypic slices, which means in vitro. And also, and this was also shown by Dr. Waters, it is then, if you add human complement, then you find demyelination. So you need, obviously, something more rather than the antibodies alone. And if you compare the antibody NMO, aquaporin 4 antibodies and MOG antibodies in their capability of inducing complement, then this is clearly in favor of the aquaporin 4 antibodies. So they are very strong complement activator, which means this is an indication of their strong pathogenic characteristics. And one of the major, I think, demands also to call a disorder a antibody-mediated disorder is the transfer of a patient serum or plasma alloate in a respective animal model, which then causes the disease. And this is the case for NMOSD, and this was the seminal work out of the lab from Hans Lassmann and we were also, Markus Reindl and myself, involved. And you can see that if you concentrate the plasma exudates or eluates from NMO patients, concentrate them, take the antibody aquaporin 4, inject them to animals, you get an NMO-like disease in the animals. So this is a proof that that antibody transfer works and the pathogenicity is also transferable. Now, if we wrap this up, and we heard now from Dr. Waters and also myself that we have demyelination by antibodies in rodents, in co-transfer models, we have pathogenicity of human antibodies, but in vitro. It strongly depends on the epitope specificity, which is quite challenging in MOG antibodies. And if we look at the human condition, the role in human condition is in vivo unclear and at best indirect. So we find in CSF antibodies in some patients, not in all patients. We have the IgG staining, as we have seen before, in MOGAD lesions in neuropathology, but not in all of them. And we have MOG antibody titers, which are usually elevated around attacks, but not necessarily exclusively, and also not sustainably. So they are indirect, because the direct, as I said, argument that they are truly pathogenic are missing. And one of the additional requirements for proving that a disease, a neuroimmunological disorder, is antibody-driven is also an antibody targeting therapy, or at least B-cell targeting and then slash also antibody. And this is in some cases the case, but not in all cases. And compared to also what we heard before, compared to NMOSD, those B-cell depleting therapies, especially the one which was looked at in this larger study, Rituximab, did not work as well as in other clearly antibody-mediated disorders like myasthenia, we will hear later, and also NMOSD. So if we have a table of requirements of B-cell mediated neurological disorders, and this is myasthenia gravis, Guillain-Barré syndrome, MAC positive, MAC antibody-driven IgM gammopathy, etc., 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 including CNS demyelinating disorders or inflammatory disorders like MS, NMOSD, MOGAD, then we find that there are those diseases which are clearly, definitely, and exclusively driven by antibodies. So they are due to antibodies. In the other case, the antibodies may play an important role, as I said, diagnostic role, or also kind of extent of the damage. However, the proof that they are truly pathogenic is still, let's say, awaited. So my conclusion is, so far, we don't have a clue that those antibodies are truly pathogenic and the disease is due to the antibodies. But, and this is the last two slides, it might be, like in many other neuroimmunological disorders, that the antibodies are only the tip of the iceberg. And the antibodies are, of course, in a major interplay in any disorder, also with respective T cells. And I would like to highlight one of the reviews very recently by Scott Zamfil last year published. I think it's very interesting to read this. It's a good wrap-up of what we know today. And I would like to highlight that MOG-specific T-cell receptor transgenic mice develop spontaneous optic neuritis. T-cell receptor transgenic mice. And on the other hand, if you have MOG-specific BCR, B-cell receptor knock-in mice, they have high levels of MOG antibodies, but they do not develop spontaneous EAE. So obviously there is a need of MOG-specific T-cells. And having said that, I would like to remind you, and I think from our own clinical experience we know that a very large group of patients develop ADEM or also nowadays MOGAD after an infectious prior disease. So this is, I think, a very good argument, for example, for a mimicry situation. And again, I think this may also should drive and prompt us to look more and to learn more from the old animal experiments, which are mainly driven by MOG-specific encephalogenic T cells. And as an offspring, we also have antibodies for diagnostic purposes. And I think the exclusivity of the MOG antibodies is in comparison with NMOSD, but not to other potential conditions. And with that, I was asked also to have a last slide on the recognition and invitation to the next Congress in Poland, and thank you very much.
Thank you very much, Thomas. Patty, could you come up as well? And we'll maybe ask you both to stand by the podium. We'll have a brief rebuttal, about 1 to 2 minutes, and Patty goes first.
Great job.
Great. Thank you very much for that uninspiring talk.
So we will write a review right now, right? Pro and con.
So if we're looking for T-cell mediated disease like in MS, then we expect an excess maybe of CD8 positive T cells, which we don't see in the tissue. The pathologists haven't looked for granzyme B or CD107 to look for degranulation with T cells. And in the paraneoplastic diseases, we find T cells, and they're a really nasty, destructive thing. And maybe in a subset of MOGAD, there is a bit of destruction, but I don't see T cell effector functions there. For the proof that aquaporin 4 is a pathogenic antibody and MOG is not, if you take aquaporin 4 and stick it into the brain of a mouse on its own, it does nothing. Maybe internalization area postrema, but you don't see that. If you put MOG into the brain of an animal, you see effects straight away with just the antibody, although we did have a little bit of complement. But I don't know whether that's relevant or not. So I think we have good evidence that MOG antibodies are directly pathogenic, and I think you win either way as the promoter of the antibody in the first place.
No, as I said, I agree with everything you're saying about, and of course it's a kind of bit of also internal controversy to have a kind of statement yes or no. But nevertheless, I think on the other hand, I think we are. I think the MOGAD is a good example, which was mainly driven by the clinical phenotyping, the identification, oops, this is an interesting case and has a strange MRI finding, and then we look for what could be the driving condition or what could be the diagnosis, which means that we have a very broad heterogeneity in this disease, and every day you will find a kind of case report which is also associated with the MOGAD. I personally believe that, again, and of course I completely believe the neuropathological findings from Romana Höftberger, yes, no doubt, yeah. But again, I think that it might be that we have now a kind of umbrella term for a group of diseases, which, by the way, is still rare, a group of diseases which is defined by the common denominator finding of MOG antibodies, but not necessarily that they are driving in every single patient the same condition. And it might be that in those cases, like in pediatric ADEMS, you will find more a T-cell mediated disorder, and in others a more B-cell mediated or antibody mediated disorder. I think it makes sense to still work on that and to prove the one more in depth and also the other one more in depth. So, and at the end of the day, also to find out whether we are, and you know, once an eminent neurologist said, if we don't have any idea, we start classifications. And I don't want to subtype MOGAD, but my personal and we have a large series, as you know, from Paul Romer. We have a large series of more than 150 or 60 MOG-AD patients, or patients with positive MOG antibodies, but they behave different, clinically, therapeutically, so probably we need to dissect this in more detail.
We have time for a few questions from the audience, brief questions. Would anybody like to come to the microphone? Dr. Kalinowski.
Hi, thank you for great presentations. And my questions to Professor Waters, maybe, unless Professor Berger would like to address that too. On pathology, sorry, we rarely see MOG loss in the tissue. So in AQP4 mediated NMOSD, there is a profound AQP4 loss, which kind of proves our concept that it is pathogenic. And in MOG cases, with some exceptions, Romana's group mostly did not see MOG loss at all. So there's several theories on that. Of course, MOG is in the macrophages, but it's not lost. So if you compare it with MAG or PLP, there's no difference. Why do you think that is? What's your explanation, and how does it come into the picture, whether it's pathogenic or not?
Thank you for the question. I think my interpretation of the paper was slightly different to yours. I saw there was an equal or an equivalent downregulation of PLP, MAG, and MOG within the lesion sites, and there's some very clear lesions without MOG at all. And in the Japanese paper as well, I think they show the same thing. So if you look at the periplaque white matter, there's higher levels of staining compared to the lesion itself. So I think there is MOG loss, but there is, it's replete with aquaporin 4. So the aquaporin 4 is untouched, if not maybe a little bit elevated.
I also would like to add probably, I think MOG is a very interesting, and I cannot deny that I have a very strong interest in the MOG since decades, but it's a very interesting molecule because it is expressed only in mature oligodendrocytes, which is a good thing probably, because if you have, for example, a disease which is truly, be it T cells or B cells or antibodies mediated, then you have a good precursor cell pool, which is unaffected because they don't express MOG. And indeed, if we look at older clinical own experiences with patients with huge, even frightening tumefactive lesions, turning out that they have antibodies, whether they are pathogenic or not, but a lot of those patients have a quite good disease course. So you could also argue that apart from whatever you're finding, you have a good regeneration pool, and this is completely different to other antibody-mediated disorders, especially in aquaporin 4. So this may also account for some, let's say, various myelin destructive areas in a disease which might be called antibody-mediated MOG disease.
Thank you. I apologize, but we're behind time, so I hope you'll be able to find the speakers and ask your questions afterwards. We're going to go on to the final voting, and the speakers can stay up here and get a good view of the voting. Let's go to the question. Same question, is MOGAD due to anti-MOG antibodies? And we're going to wait 10 seconds. Okay, so about 65% said yes and 35% no. Still the majority, now we're at 86% say yes. So it looks like very little change compared to before, but thank you very much to the debaters for an excellent debate and enlightening us. And now we'll turn to our next debate, and we're going to move from the central nervous system to the neuromuscular junction, and from pathophysiology to therapeutics. And the topic is time to redefine generalized myasthenia gravis. Are corticosteroids the backbone of myasthenia gravis treatment? And Professor Berger will be our moderator.
Yeah, thank you again, and I'm now glad that we move from the central to the peripheral neuromuscular compartment. And yes, indeed, there is a kind of controversy over the past decades with the question, are the corticosteroid, but also, let's say, the unspecific immunosuppressive treatment, the backbone, apart from the symptomatic treatment, the backbone of the treatment of myasthenia. And this is quite relevant because on the one hand, we have a lot of experience on that over the past decades. On the other hand, of course, we are also seeking for more specific treatments, and we are also faced with approvals of new treatments. So the question, therefore, is, and the debate, I don't want to say controversy, but probably debate, circles around how to adapt and balance the experiences we have collected over the past decades in the treatment of myasthenia gravis patients, and also the expectations we have in the new, especially monoclonal antibody therapies. And for this debate, we have two very experienced speakers. I would like to start with the no speaker, because it's in honor that Professor Anna Kostera-Proschik is head of the neurological department in Warsaw, and a member of the Council of the Center of Excellence for Rare and Undiagnosed Diseases at the Medical University in Warsaw. At least probably myasthenia is not that rare and underdiagnosed, but the treatment-failed myasthenia are then part of a rare disease disorder. And she's also head of the EuroNMD Center, the Reference Center for Rare Neuromuscular Disorders. So no one better to talk about or taking the part no, this is not the case. And on the other hand, I would like to introduce Professor Hakan Çetin. He's a consultant neurologist. I know him very well because he's from the same department of the Medical University Neurological Department in Vienna. And he has been also dealing with neuromuscular disorders, specifically of myasthenia, for a long time. You have been in London for this purpose, also looking at specific basic neuroscience aspects of myasthenia. And he is, of course, very strongly engaged in our neuromuscular group in diagnosing and treating myasthenia patients. And without any further delay, I would like to call you, Dr. Çetin. I have to vote. So let's expect what will be the voting question, but you have to, again, scan, and then is the question, is there time to redefine generalized myasthenia gravis? Are corticosteroids still the backbone of the MG treatment? And so this is a bit a tricky question, because it's is it time to redefine myasthenia gravis? And the other point is, are corticosteroids still the backbone? So you can choose where you would like to place your yes or no, in which part of this sentence. Okay, so we have now 72%, 74% agreeing. We will recall this at the end of the session. But now, I would like to call Professor Çetin to present his yes position as a kind of setting up the scene then for Professor Kostera.
Thank you for the introduction, dear chairs, dear colleagues. So I'm very pleased to be here to speak about myasthenia gravis and whether it's time to redefine generalized myasthenia gravis. So over the next couple of minutes, I will outline why I think that corticosteroids are still the backbone of MG treatment. This slide displays my disclosures. I have no disclosures in the context of this talk. So while we are fortunate to have an expanding repertoire of targeted therapies, corticosteroids have stood the test of time since the identification of the therapeutic potential in myasthenia gravis in the 1950s. And corticosteroids offer rapid and consistent efficacy. They are widely accessible, and they provide an adaptable tool in MG management. So what matters in MG treatment? We expect from a drug to be effective, to have an advantageous safety profile. A drug should be easily accessible and ideally cost-effective, and a drug should provide flexibility within treatment regimens. So we have a different number or a different number of factors covered under each of these headlines, and corticosteroids meet many of these key requirements listed here and highlighted in green. So let's have a closer look at efficacy with a focus on clinical response and the speed of onset. We have data from randomized controlled trials published quite a couple of years ago in 2005, which summarize 7 randomized controlled trials on the effect of corticosteroids in myasthenia gravis. And one insight here is that these randomized controlled trials have included low case numbers, limiting their statistical power. So only 3 studies here were able to perform statistical analysis, all showing significant improvement in treated patients. But overall, the conclusion of this Cochrane review is that we have limited evidence from randomized controlled trials, and however, these evidence is supportive of conclusions from observational studies and expert opinion. So let's move on to observational studies. I have listed maybe 5 of the most representative observational studies here. They are heterogeneous with respect to corticosteroid dosage and formulation, but one advantage here is that we have higher case numbers. And one conclusion we can draw from this data is that steroids are effective in treated patients. So here we have, in these studies, it was reported that clinical remission and a marked improvement could be observed in up to 90% of the treated patients. So what about safety? Steroids are so harmful. This could be a concern of one of our patients, and this definitely reflects the negative impression of steroids in the overall population. But are they really so harmful? So here we can again have a look at the observational studies which reported adverse events occurring in about 40 to 70% of the cohorts. Some of them are quite common, including weight gain, cataract, diabetes mellitus, Cushingoid appearance, hypertension. So these are quite common side effects and adverse events, but we have to take into consideration that these adverse events are dose dependent, and we have here different patterns of a dose dependence. One is the linear pattern and the other one is a threshold pattern, which means that some quite serious adverse events might not occur that frequently if we manage to reduce corticosteroid dosage below a specific point. Apart from adverse events, we have corticosteroid-induced exacerbations, which means a deterioration of the clinical symptoms within the first 1-2 weeks of corticosteroid therapy initiation, which is mainly due to a transient upregulation of the immune response due to corticosteroid treatment. And the observational studies showed that this transient exacerbation occurs within the first week with a mean of 5 days after initiation of the therapy. And it can be quite frequent. It is observed in up to 50% of the cohorts. So as a result of these drawbacks, which we definitely have in the context of corticosteroid treatment, we have to individualize corticosteroid treatment, which means we have to consider and manage the individual risk and try to reduce corticosteroid exposure to the minimally required dosage and duration. And this can be achieved by starting additional immunomodulatory treatments or by performing thymectomy. So we know we have clear evidence that by these measures we can have a steroid-sparing effect. But here again, we have to take into consideration that this steroid-sparing effect becomes evident only after quite a long time. So in the case of azathioprine, we see this effect after 6 to 12 months after therapy initiation. And this again means that for this quite long time, the clinical effect mainly relies on the corticosteroid dosage. But what about the novel targeted immunotherapies? Since we have entered a new era of potential of new possibilities in the treatment of myasthenia gravis, but what happens to patients currently receiving corticosteroids when they also receive another novel targeted immunotherapy? And here we have real-world evidence now showing that, so this real-world evidence shown here is on the effect of C5 inhibitors, which is eculizumab, ravulizumab, and the modulator of the neonatal FC receptor, efgartigimod. And what we see here that these novel therapies are potent enough to reduce the corticosteroid dosage in most of the patients, but still quite high proportions of these cohorts continue to require low corticosteroid dosages. And this again supports the argument that steroids still in the era of these novel therapies remain the backbone of MG treatment. We have novel international consensus guidelines for the management of corticosteroid-related complications in neuromuscular diseases. So these guidelines have just recently been published, and we all should be aware of these guidelines. For the sake of time, I will not go into the details of these guidelines, but I want to highlight maybe one major conclusion of this talk, that we have to tried to identify the individual risk in each of our patients by performing a thorough examination before therapy initiation, before the start of corticosteroid treatment, to assess the individual risk. So let's move on and look at the therapeutic guidelines. What do these guidelines recommend? And here in this table, we have a therapeutic algorithm from the guidelines of the German Society of Neurology. And these guidelines clearly recommend corticosteroids as the first-line treatment in all forms of myasthenia, in ocular generalized myasthenia, in AChR antibody, and MuSK-positive myasthenia. What about the international consensus guidelines? They are pretty much in line with the German guidelines, recommending corticosteroids as the first-line treatment in myasthenic patients. And what about Japan? Here we also have guidelines, again, recommending low-dose prednisolone as the initiation, as the initial therapy in ocular and generalized myasthenia. But corticosteroids have even more advantages. So as mentioned before, they provide flexibility within treatment regimens. We can use them across all MG subtypes. They can be combined with all kinds of treatments, and they can be used as a bridging tool. And they are widely accessible, they are cheap, they can be afforded by healthcare systems. And taken together, this brings me to my final slide and to my initial question. So are corticosteroids the backbone of MG treatment? I think they definitely are, at least in most patients, after an initial individual risk assessment. Thank you.
Yeah, thank you very much. We will now hear your opponent.
Good morning. It's a really tough role for me to try to convince you that corticosteroids do not longer have a role or are not the backbone of MG treatment. In fact, though we worked on our presentations in quite separate ways, some of the slides will be quite similar. Here are my disclosures, and I would really like you to pay more attention to the dark side of the moon, because, of course, introducing steroids to MG treatment was a great breakthrough. This was something that changed the lifetime course of many myasthenia gravis patients and really made many of us neurologists choose myasthenia as the field where we wanted to be involved into, because we could really help our patients. And if you ask me, what is the overall amount of steroids that I ever prescribed to my patients, I would say guilty as charged, a lot. And I was as happy to see their improvement, but also I recognize that it's very hard to control all that steroids bring with them. Of course, the onset of activity of different treatment that we have is very important for MG patients, for any MG patients, from the mild ones with ocular symptoms. Diplopia can really badly affect activity of daily life, to the severe generalized patients. And of course, glucocorticosteroids were for a very long time the only one, except for what we consider as a rescue treatment, PLEX or IVIGs, that could lead to improvement within just a few weeks or a few months. For the onset of action of any other things that we have had for many years, we really had to wait quite long before tapering steroids could be done. I really think it's very good to look to what treatments does, not only through the eyes of the physicians and the outcome measures, but also through the eyes of the patients. And I think it's no surprise that patient-reported outcome measures become a very important part of the what we do for the clinical trials nowadays. It's not only about making a person better on a scale, about reducing the risk of myasthenic crisis. Nobody would argue it's important, but it's also about making the life of the patient comfortable. It's also remembering that, first of all, people with myasthenia can now enjoy long and happy life. They can live with myasthenia for 50 or 60 years since the time when they were diagnosed. And many of them, approximately 1/3, may require far more than just a symptomatic treatment for the lifetime. Another thing, We have a flood of patients with late and very late onset of disease, people who are diagnosed when they already have a number of comorbidities, and this really has to be taken into account. So comorbidities represent a significant challenge, and I highlighted in red what can be related directly or indirectly to long-term corticosteroid use. And of course, for some situations, this is not a simple yes or no question. We have to very nicely balance what is in the best interest of our patient when we make the decision, but also for the long-term perspective. Of course, the adverse event profile of steroids, this is something that is a textbook knowledge. We all learned it in medical school, but we know quite well what to advise our patients to control those adverse events, but it's not very easy to follow this advice. We see that more and more people have obesity. It's not easy to control diabetes, other metabolic problems. Even tackling osteoporosis can be quite challenging for many of our patients. So with a very large number of conversations with patients, the experience with long-term steroid treatment was not that favorable as we physicians sometimes may think. Of course, when we start treating the patient, we also define the goal of treatment, and of course we would all love our patients to go into complete stable remission, meaning no drugs, no symptoms. It is achievable, depending on the report, in approximately 30 to 50% of the patients in the long run, but it's often quite a long journey. But we also know that when the patient defines what severity of symptoms is really not bothering them anymore, what is the patient accepted symptom state, the threshold is set very, very low at just 2 points MG-ADL score. And as you can see with corticosteroids, this is not achievable. And definitely the patients expect far more from the treatment that we currently had for them. Of course, all the guidelines that we have, the most recent guidelines that already included information about the novel therapy that have proven efficacy and well-defined safety profile and are approved for myasthenia gravis, they mention steroids as a very important part of treatment, at least for some patients, maybe early on, maybe before they really can reach this satisfactory state with low dose. But as it was already said, steroid-sparing strategies are a very important part of the standard of care. So, steroid-sparing strategies in MG, similar slides that you have seen, and of course thymectomy. The method that has finally a proven efficacy in seropositive early onset myasthenia gravis, and it really leads to a long-term reduction of cumulative steroid dose, but it also increases the probability of reaching minimal manifestation. So this is something that I would still call a backbone of MG treatment in early onset generalized MG patients. We really want to have them well in the very long run. Surgery still has a place. For the steroid-sparing immunosuppressants, of course, we have those classical studies that were already shown just a few minutes ago. Azathioprine has this steroid-sparing effect that was demonstrated, and the difference was seen not after 1 year, but after 2 and 3 years of concomitant treatment. We have a list of other steroid-sparing immunosuppressants really showing that we put a lot of effort to get rid of whatever was the miracle drug for many of our MG patients in the past. The goal to go down to the daily dose of 7.5 milligram prednisone or equivalent, I think we most will agree that it is very hard to achieve in many of our patients. Those that are easily taken off steroids, these are the lucky ones who enter complete stable remission. Some of them may do well just on non-steroidal immunosuppressant. But in many reports, the median dose of steroids is far above this level, and it's very difficult to take the patients to 7.5 or even less. When we look again at this balance between the action onset and the adverse effect severity for various treatments that we currently have, and we see the new players that came in the recent years, including FcRn inhibitors and C5 inhibitors, we have a much more favorable situation for our patients, because if we aim to improve the patient not within 2 or 3 years, but within weeks or a few months, it's not just steroids and the rescue therapy. We also have new options with very quick onset of action, and as we have seen, this medication can also lead to reduction in the steroid requirement for our patients. We have new fast-acting, well-tolerated treatments that address gMG pathology, and they have multiple benefits. They act really very fast, sometimes within hours after infusion. They are well tolerated. They have limited side effects. Of course, we will collect more and more data from clinical trials and from real-world reports. They are better addressing the pathogenesis of myasthenia gravis, and then really can offer a great option for the patients who do not really respond that well, that we can take them off steroids altogether, or really limit the dose to whatever does only the good, but no, or almost no harm. So I would like to convince you that corticosteroids are no longer the backbone. They are just one of many pillars. And I really hope they will not be the strongest pillar in the future. These are pictures from Krakow. So I hope that I not only convinced you to not look into steroids so much for MG patients as we used to do, but also to come to Krakow next year. Thank you.
Thank you very much. And I invite you now to also enter the stage. And now the infight starts.
So I think there will be no fight. I rather think that both talks complemented each other. So I completely agree. We should try to reduce corticosteroid dosage as quickly as we can. But in my experience, in reality, we do not manage to taper it off completely in a short time. So that's why we still depend in most situations on corticosteroid treatment. And that's why I would say that corticosteroids, and as stated in the guidelines, are still one major stone in the repertoire we have for MG treatment, together with thymectomy, which definitely is another backbone of MG treatment.
Well, to put a good fight, I completely agree with you. I really think that the landscape for MG treatment is finally becoming more nuanced. We had just a few ways to go for our patients, not quick enough in the time of onset. I think that one of the most frustrating thing in treating severe MG patient was really keeping the patient on high-dose steroids and waiting for azathioprine or mycophenolate to finally kick in. I think that in many countries we still have certain threshold for IVIGs in MG patients, so it's still really the rescue therapy, and we really need something in between. So though I should say no steroids, no more. This is not my thinking, but I would say less steroids and maybe more options for the patients to save them from all those really severe side effects that they develop, despite our efforts to reduce the risk. It's not very easy to really control every side effect of long-term steroid treatment. I hope you agree.
Yes, I completely agree. And one conclusion from the both talks is may also be not to start as we used to do in former days at very high dosages. So many recommendations suggest to start with high dosage with 1 milligrams per kilogram body weight. Most centers do not follow these recommendations, so we start with much lower dosages, but we step in early with another treatment, with another steroid-sparing treatment like azathioprine, or in other cases with IVIG, etc., and try to reduce corticosteroid dosage as quickly as we can.
Yeah, and I also agree we really have an approach with steroids. Start low, go slow, stop when the patient really starts improving. I can't remember the times when we really follow this 1 to 1.5 milligram per kilo dose for the patients, because we are aware of all the disadvantages of such long-term approach.
Yes, I completely agree.
Great. Are there any questions out of the auditorium? Yes, please.
Thank you for the excellent talks. Anthony Bernard from Paris. Do you think there is a more widespread use that could occur in the next few years with the fast-acting treatments in the first place? You know, there were these Japanese recommendations saying it's very important to treat early and hard and use fast-acting treatment. What is your opinion about this subject?
There are several interesting studies, and I think it's worth to mention the RINOMAX study about Rituximab, that is the study published by the Swedish group with Rituximab early on for seropositive generalized myasthenia gravis patients, and with one observation, it really led to very good effect. I think that MG is in a way now trying to follow the footsteps of MS world, with maybe looking also for some, as you suggested, therapies that can control disease quite well early in the disease course. One of the ways is with the patients who have generalized seropositive MG, not postpone thymectomy. Of course, the effect is not immediate, but it really leads to good long-term outcome for many of the patients. So I think this is still something that we have in our repertoire.
I would also, just one statement, I think the approach with hit hard and early makes sense in myasthenia gravis. Why should we wait, for example, for complement to destroy the neuromuscular junction where it may not be reversible anymore? So from a mechanistic point of view, it makes sense to step in with complement inhibitors very early, but we do not have the data yet. And one one major aspect is that the novel therapies are very expensive still. So I think there are still many countries where they cannot be used that regularly or that frequently. But this will definitely change in the next years, and we might get there where multiple sclerosis is now. So there I think it is more common to start with a hit hard and early approach, and we will get there in a couple of years with myasthenia as well.
Question for both of you. Sometimes when we have a patient with a near crisis and we start steroids, you can have a transient worsening. So do you think we should avoid steroids in any subsets, like in near crisis?
As for the high-dose steroids in the patients who already have acute exacerbation, the approach that is recommended in the guidelines, but what we also do in our center is if the patient is already in a full myasthenic crisis on a respirator, then we can go with high steroid dose. The patient has already exacerbated, we really fight for quick improvement. But if the patient has severe dysphagia, is really developing bulbous symptoms, we avoid high-dose steroids. We first stabilize the patients with Plex or IVIGs, and then adjust the dose of the immunosuppressants, including steroids.
Yes, I'm completely in line with this approach. So in a severe crisis, or in a severe exacerbation in an unstable patient, I will try to stabilize the patient with IVIG or immunoadsorption. And then in a secondary step, I would start with corticosteroids because we have a much quicker, much more rapid effect with the IVIG and the plasmapheresis or immunoadsorption.
Thank you very much. I think we should vote.
Yeah, please let me, I would like to add one thing, because I received a very funny comment from obviously someone who has a lack of humor, because said I completely misled the question. So the question does not regard the redefinition of myasthenia, of course, but the question regards the corticosteroid still backbone. So to clarify this, even for those who are a little bit more anarchistic than I am, thank you.
To clarify, if you believe what we heard in the affirmative, that corticosteroids are the backbone, please vote yes.
Yes, and we met in the middle.
Thank you.
So any comments, further comments from you two to the voting results?
Thank you. I'm really glad at the result.
Yeah, me too. We met in the middle.
Yeah.
It sounds as if you both largely agreed.
Thank you, both of you. And now I think...
So we'd like to close this wonderful session. Thank you for the speakers, for very, very interesting presentations. Dr. Weinshenker, Dr. Berger, and please remember to come back after the coffee break. We'll re-adjourn at 10 minutes past 10 for the opening ceremony. Thank you very much.